And he's our newest faculty member, as many of you may know and others may not, in epidemiology. He joined us just this summer. We acquired him from the Division of Infectious Diseases and in the School of Medicine. He's got an amazing CV, I think, for real rapid accumulation of some really well-cited publications. And he's an alumnus. He's a graduate of this School of Public Health in 2011. So we're really, I think, happy to have him. He's going to was already bringing a lot of new strengths to our program in epidemiology, not just his knowledge of infectious diseases, but also he's really sophisticated with statistical analyses and their application. We're looking forward. He's already leading our advanced epi class, and he's plotting out an even more advanced version of computational epidemiology to be offered, I think, sometime in the future here. And he really makes R, which we've been trying to get into our curriculum, stand up on its hind legs and bark like a dog. And what else can I say? Brian?
His wife's a lawyer. He plays guitar.
There you go. And he likes beer. Take it away, Ken.
Best carbohydrate. Okay, should we get going?
Yeah.
Let's do it. All right, thanks everybody for coming. Good turnout. Hopefully it's not too depressing for everybody. So, I have to start and say that I'm not an expert on health disparities by any means. I like to call myself an expert on pneumonia, but I'm probably not that either. But I really like it, and I've researched pneumonia for a very long time. So there's not a lot, as you'll see, research on health disparities in pneumonia. And we thought, given the data that we have, this might be a good opportunity to take a look. So pneumonia is the leading cause of infectious diseases-related death worldwide, not just in the United States, worldwide. In fact, in the United States, pneumonia has been the leading cause of infectious disease-related death since 1900, probably since the beginning of data collection. So it is super common, and it's really bad. But it's a syndrome. It's not a particular disease, so health departments don't collect data on pneumonia. So we can really know what incidence was. For those of you who aren't really knowledgeable about how pneumonia occurs, this is what the inside of your chest looks like. We're talking about lower respiratory tract infections here, just below your vocal cords. So there's three types of lower respiratory tract infections: pneumonia, acute exacerbation of chronic bronchitis, or COPD, and acute bronchitis. So we're just going to talk about pneumonia. Dr. Woods will, in fact, show you exactly what pneumonia looks like. So, your alveoli in your lung, these little pockets here, that's what really transmits oxygen into your bloodstream. And that's what you want, right? Because we need oxygen to live. When you get pneumonia, pathogen gets in there, you get white blood cells that go to the area, and Dr. breaks all kinds of stuff. But, so you get pus in those air pockets, and you can't breathe because there's no air-oxygen exchange anymore. So it's really bad. We don't want that to happen. If you get pneumonia, you get an X-ray. Oftentimes, this is what it might look like. This is called an infiltrate. So this should be black, just like the other side. When that's filled in with pus and all kinds of other immune cells and dead bacteria and things that are really blocking your body's ability to exchange oxygen. I said we were going to talk about, in the title, if you read those super long titles, it's too long as Dr. Lockhart mentioned, but we're going to talk about the incidence of CAP, we're going to talk about severity of CAP, community-acquired pneumonia, and we're going to talk about the outcomes of patients that get CAP once they get to the hospital. So CAP is super common. In fact, it's way more common than we initially thought it was. So if you look at any CDC documents, they say the incidence of community-acquired pneumonia in people walking around like us is going to be somewhere in 120 per 100,000 individuals. So Jefferson County, 750,000 people, 7 times 100, and we're looking at maybe 800 cases of CAP in Jefferson County a year, something like that. But now, the most recent data suggests probably somewhere closer to 650 cases, age adjusted per 100,000 individuals walking around. So that's a lot more common than we thought, a lot more common. In fact, you can look across age ranges of pneumonia on the right. So in Jefferson County, these are data from Jefferson County, for people walking around in Jefferson County that are over 85 years old, for every 26 85-year-olds or above, we're going to get one case of pneumonia from that group in a year. So if you're old, you're getting pneumonia. There's no getting around it. It's known as the old man's friend. So that's incidence. Severity. There's a lot of ways to measure how severe the case of pneumonia that you have is. One really common one here on the left, this is a data collection form for the Pneumonia Severity Index, published in the New England Journal of Medicine, and really renowned for being this great severity score tool. I have a lot of data that say it's pretty terrible. But really just assigns points to if you have certain comorbid conditions that are associated with getting pneumonia, or having really, not with getting pneumonia, but dying at 30 days after you get pneumonia. So you get all these points, and then you get a score, and then you get classified into these 5 different risk classes. So risk class 5 pneumonia is supposed to be really severe. Risk class 1, you can probably just go home and get some antibiotics, you'll be fine in a couple of days. Big issue with this is it's heavily weighted on age. And we know pneumonia is the old man's friend, but not always. With H1N1 pandemic influenza, people that were dying because they had pneumonia. But everybody that was getting it was young, right? So the PSI didn't work at all for those patients because it was all young patients. Probably now what's best is the one on the right. So these are what's in the guidelines for international guidelines for community-acquired pneumonia. These criteria are what designate you as having a severe CAP. You can have a major criteria at the bottom, or you can have a couple of minor criteria on top. Outcomes are not good. So you get pneumonia. Again, think about these 85-year-olds that are walking around. They're going to get pneumonia this year. What happens after you get pneumonia? Well, in the hospital, you're going to stay in the hospital about a week to 2 weeks or so. 5 to 10% of those individuals are going to die while they're in the hospital, of all causes. So again, it's very difficult to tease out pneumonia-related mortality, because when you get an infection, your body responds often generically. You get cytokines release, all these molecules that increase inflammation systemically. And a lot of times, those molecules, like cytokines, will dislodge plaques in your arteries and cause a heart attack or a stroke or some cardiovascular condition or other things. So that, you might see on the death certificate, it says, heart attack, whatever. But it was due to pneumonia, because that was the event that precipitated the cause of death. So 30 days after you get out of the hospital, what's going to happen? 10 to 20% of those people are going to die. And then 1 year after you leave the hospital, 40% are already dead. And we have a lot of data to support this. Not just our group here on the left, it's for VA patients, so generally white males over 50 years old, admitted to the medical intensive care unit. We're looking at people that were admitted with pneumonia on the bottom and due to some other medical condition on the top. We adjusted for various comorbidities using the Charleston Comorbidity Index, but you can see over 7 years there's a wide difference in survival. And on the right, you can see Michael Fine's group, who developed the Pneumonia Severity Index, also found similar results. There's other important outcomes too that we like to look at. One is clinical stability. So how long does it take you to just get better? When does your cough go away? When can you take things by mouth? When does your fever go away? That kind of thing. And clinical failure. So after we started treating you for a couple of days, you get worse. So that's failure. So on to the health disparities. I don't have to probably tell this group too much about health disparities, so you know way more than I do about this stuff. But health outcomes are different among different groups of individuals. It's not all income-based, it's not all race-based, but of course these are critically important factors. We know from a wealth of studies and a huge number of health indicators that income and race are really important factors as far as health disparities. But now, I learned from Dr. Wallace that what we like to talk about is socioeconomic position. And there's a lot of things that measure what your socioeconomic position is. I'm not going to go into this too much. I can provide some research for it if you want to do a little bit more. The folks at Harvard have provided this. What I really liked was the difference between socioeconomic status and the difference in socioeconomic position, because I didn't fully understand this. But socioeconomic status that we usually see in a lot of literature says, socioeconomic status is associated with whatever. It kind of blurs the line between what the two distinct elements of socioeconomic position are. So your actual resources and your status, your social class. So we're going to try to focus more on socioeconomic position, but it's of course difficult to measure. All these things can be very, very difficult to measure. But we're going to use this concept of social deprivation to try to measure socioeconomic position. So why deprivation? So we can go back to 1983. Who remembers 1983? What was happening in the United States in 1983? Anything important? Happening in the UK, and not University of Kentucky, but the actual UK in 83. Thriller and Karma Chameleon. Two great songs. 83 was actually the first time Michael Jackson did the moonwalk as well. Not that long ago, but it seems like a long time. I was 4. But really, this is what was happening. The United States released this report called Health, United States, 1983. Saying major disparities existed in the burden of death and illness experienced by blacks and other minority Americans compared with the nation's population as a whole. So we were just starting to think that, well, there may be some disparities happening. In Europe, they were well on the way. They knew this a long time ago, and they were already developing tools to be able to measure that, to be able to conduct studies for it. And this is where deprivation indices initially came from. This German article, there's another Thompson indices, there's all kinds of deprivation indices that have been used throughout Europe for a very, very long time. So we're looking at spatial deprivation, the area deprivation indices. So it's difficult to measure individual level deprivation because collecting data individually for something like this is going to take a pretty long patient interview. And we didn't have those data. But there are area-based measures that you can use. So using census data. So in 2003, Gopal Singh, if you've read a lot about disparities, his name seems to be everywhere, developed this area deprivation index in this article in the American Journal of Public Health. So it was using census data and aggregating it together, using factor analysis and a bunch of other things to be able to get weighted measures of the impact of various census variables on what he thought might be related to your deprivation. If you live in a specific area that appears to be deprived based on all these factors, then you're more likely to be along the same lines, birds and feathers. So this was a long time ago. It was updated by the University of Wisconsin for new census data, and they published really the methods on to be able to do this yourself. And that was based on census tracts. So if you know geography, we have counties, and then we have census tracts. Census tracts are supposed to be about 4,000 people. Of course, if you're into geography, I've never talked about the zip code to anybody who knows anything about geography. It's the most useless thing ever, unless you really want to get your mail, and it's really important. But that's it. And then one step further is the census block group. So folks at Paramount Healthcare in Utah expanded this deprivation index calculation to be able to do it at block group level, because block group is a much smaller, more precise area to look at. So if you're in a block group that is kind of defined as deprived, you're much more likely to be, that might be your individual level deprivation index. So here are some variables. I can provide these articles to you if you wish to look at them further. I'm not going to spend a whole lot of time on it, but a bunch of different census variables, using some various statistical methodologies to apply multipliers to each value. So we did this because there's really nothing out there in the field of pneumonia as far as health disparities. There's a couple. So in 2010, American Journal of Public Health, CDC folks did this one, socioeconomic and racial ethnic disparities in the incidence of bacteremic pneumonia. So bacteremic pneumonia is when the bacteria gets into your blood and you get a blood culture and you find a bacteria there, plus you have pneumonia. Really, they're just looking at one specific cause of pneumonia, Streptococcus pneumoniae. It's thought to be the most common pathogen associated with getting pneumonia. Probably not the case really anymore. But they were looking at this census tract level census variables. So not a deprivation index, but individual variables. So they were looking at income and race and various things at a census tract level. And what they found was actually very interesting and very sad. So we have these white bars being the white non-Hispanic individuals, and you can see as census tract poverty goes up, the incidence goes up. For black, it goes way up. For Hispanics, it also goes up. So what do they find here? This is actually pretty astounding. Incidence of bacterial pneumonia among black adults living in the most impoverished census tracts was twice that of whites in those same census tracts. But 4 times that of whites in the least impoverished census tracts. So this is incidence. So we're thinking about what's the biological plausibility, what's the cause of this? Because we know that in terms of infections, race individually doesn't have a whole lot to do genetically. It doesn't seem there's been a lot of studies, and it doesn't seem to predict infection very well. So during H1N1, individuals looked at exposure and susceptibility and access to care because these are critical measures as well. And the findings here was Spanish-speaking Hispanics were much more likely to get H1N1. So you think about this might be it's an infectious disease that was highly transmissible, and it was a pandemic virus, so the R0 was relatively high, so it was very transmissible. So individuals that have a more communal behavior, that may be more exposed to other individuals may transmit the pathogen more readily. And this one, probably the currently most in-depth study on disparities of care by race and pneumonia, again by Michael Fine. He seems to be everywhere with the Pneumonia Disparity Index. And this was interesting. When I first read this, I was like, what's going on here? And you'll see why I really was wondering. I was happy to find this article. Elderly African American cat patients experience a survival advantage compared to Caucasians. And there were no racial differences in the quality of care. So it seems like there's something going on that's causing health disparities in terms of the incidence. We don't know anything about the severity. Once you get to the hospital, your care is the same. It doesn't seem to matter if you're poor or rich or black or white. The care seems to be the same. But we don't know what happens after that. So that was kind of the process for this particular study, why we wanted to look at these kind of 3 outcomes. So what else can we do? Well, luckily, Division of Infectious Diseases got quite a large sum of money to do this HAPPY study. So it was hospitalized adult patients with pneumonia, an incidence study. The prior logo here was terrible. Sorry, Dr. Ramirez. So this is a 2-year study, 2 full years. 24/7, 365-day a year enrollment. And people here that were Bilal, who was collecting patients at the time, knows the pain. Didn't matter if there was a foot of ice on the ground, you were going to the hospital to enroll a patient. So literally everybody who went to any of the 9 hospitals, adult hospitals in Louisville and Jefferson County, was enrolled in this study for 2 full years. This is everybody. Mortality was measured at different time points, and we got 1-year mortality from Office of Vital Statistics from the State Health Department. So this was recently accepted for publication in Clinical Infectious Diseases, the second best ID journal there is. So that's where this figure comes from, the age-adjusted incidence rates. Again, look at this, greater than 84 years. Almost 4,000 cases per 100,000 adults. That's a huge, huge number. And of course, if you know what Jefferson County looks like, this is a heat map showing cases per square mile that Brian did. Quite a good job with that. Interstate 65, bad, not so bad. Risk of getting pneumonia while you live over here is about almost 70% higher than if you don't live in that area. So we wanted to look at these 3 outcomes: the incidence, the severity, and the outcomes of these patients with pneumonia in Jefferson County. And we use these data. We calculated the ADI ourselves using census data from, actually I think we used 5-year estimates from the American Community Survey to try to get a little more reliable estimates. We went by block group because it was a little more precise than census tract, and then we looked at those same outcomes. Analytical approaches, of course everyone uses descriptive stuff, and has anyone even heard of this before? I never heard of it. Eigenvalue spatially filtered multi-level models. That's what I was trying to tell you. So this is a way that you can account for autocorrelation when you're doing regression models that are geographically based, because a rate in one census block group is going to be more related to a rate in a block group that's attached to that block group than someone across the county. So this accounted for that. And of course, mixed effects regression, because we have individual level variables from our pneumonia patients, plus we have the area deprivation index that is more a block group level variable. I have to plug R because it's literally the best thing ever. Would never been able to do particularly this in any other program without writing it myself. So what does this look like? Descriptive analysis. So more of Brian's maps. Dots are addresses of individuals, home addresses of individuals who were admitted with pneumonia, shifted, so you're not going to be able to go in there and find exactly who it was. Not that it would matter. Jefferson County is pretty big. But again, look at this. Background, red is higher, yellow is the least. This is percent poverty by census tract. This is percent African American. Pretty similar. Interstate 65. Not here, here. Again, this is where all the cases are. A not so pretty map that I did on the fly. Brian, this is a job for you next. Area deprivation index by census block group looks the same. So we look at race by area deprivation index. This is what we saw. And we found that Black African American race had a much higher deprivation index overall, which means more deprived based on these census variables versus white. So what I ended up doing was calculate, we wanted to analyze all of this based on tertiles of this. I didn't want to use this as a continuous measure because it's a little wonky. So we aggregated it into tertiles, but I did race-specific tertiles. So everything that you see is going to be race-adjusted because we calculated the race-specific tertiles. This is the number of people that we had. So these are individuals, unique individuals that were admitted with pneumonia to one of the 9 hospitals in Jefferson County who didn't reside in a nursing home for one of these 2 years, during one of these 2 years. Pretty decent sample size. I'm going to show you a couple of tables of demographics. I've highlighted in red things that are actually kind of interesting. So there's not really anything interesting here that is unexpected. Here, okay, let's look at this. So alcoholic, double in tertile 3, which is higher deprivation. So tertile 1 is 1 percenters, tertile 2 is everybody else, and 3 is highly deprived. COPD, increase, probably due to increased smoking. HIV, low, but double. Active cancer in the past year, lower. Why is that? Probably access to care issues, or individuals that can't go at all and end up dying before they can even get to care. So they're not diagnosed. There's a lower incidence of cancer in deprived areas that they're not getting diagnosed. So look at some severity measures. So this is the pneumonia severity index. It looks like it's actually decreasing as you get up. So why might that be? Remember, pneumonia severity index is highly biased by age, and we have a wide age distribution between rich areas and poor areas. Rich areas in Jefferson County tend to be much older, so they're going to be documented as more severe just by the fact that they're older, not the fact that they actually have a more severe disease. If you look at better measures of severity, the guidelines criteria, it's increasing. So you have altered mental status, that's a good marker of a pretty severe disease. It's increasing. Need for mechanical ventilation, breathing tube, or some sort of blood pressure support, increasing, and need for ICU on admission is increasing. So we're pretty good measures of that severity is increasing as deprivation increases. Okay, so now we're going to look at some of the results here. Race-specific tertiles of the deprivation index. This is the increased trend of the incidence. So we're looking at somewhere between 300 cases per 100,000 individuals all the way up to 550 cases per 100,000 individuals. We look at some adjustment, and we can use that eigenvalue spatially filtered multi-level model to account for the block group rate autocorrelation. We can document that for every 10-point increase in that ADI, remember it went from 0 to 150. I didn't use tertiles in this. This is actually there was a 60% increase in the block group rate. So that's pretty substantial.
So are you doing some kind of adjustment for age in those?
There's nothing adjusted for in that particular model currently because it's all aggregate level data. So I could probably throw in some census block group level aggregate data, say 20%. In this particular block group, there's 20% people over 85 or something like that. So that'll be the next step in the manuscript. But that model takes forever to run, so it didn't happen for this presentation. Definitely needs to be adjusted. Okay, so severity. Again, our PSI, you kind of look and you see all the really red parts, that's more severe percent severity in the block group. There's more severity over here. That's because that's where all the old people in Jefferson County live. If you look at a better measure of severity, it's pretty well distributed throughout. You have a couple of pockets, which is a little interesting. Again, I'm going to pretty much ignore this PSI because of the fact that this is all due to age. You see it actually, this is a significant decrease in severity due from the PSI measure over increased deprivation because of age. But if we look at actual severity, seems small, but it's significant, 33% to 38% increase in translation. So really the more interesting part was the outcomes outside of the incidence. So did several models. So these are multi-level models accounting for the fact that we have some block group level variation. And highlighted up here are the tertiles. So this is all in reference to tertile 1, adjusting for all of this business. Models pretty well make sense. You know, are you going to get better faster? That's what these are modeling. Within 3 days. Early clinical stability means you got better in 3 days. So you could probably go home, probably day 4 or day 5. ADI didn't really seem to matter. Your level of deprivation for getting better once you're in the hospital getting treated pretty much the same as everybody else. Failure. So after a couple of days of care, did you get worse? Not really. Point estimates are, above 1 when you're looking at here, 1.1, 1.1. So not huge. Strength, definitely not significant. Things that make sense. If you have super severe disease, you're probably more likely to fail later. So that makes sense. 30-day mortality. Remember that article I showed you that elderly African American had lower 30-day mortality? Same thing. We'll talk a little bit more about why that might be in the discussion. But when we look up again, pretty much most of these this is an in-hospital measure of care, really, 30-day mortality. So no difference. 1-year mortality. Small but distinct dose response. More deprivation, increased risk, odds. Sorry. Going against what I like tell everybody, I'm going to kill them if they say. These are logistic models. So rounded both 1.3. So 30% higher odds of death at 1 year after discharge. So let's talk about some stuff. This is the one that I like. I don't mind, I know I do. So incidence. Why might the incidence be increasing by increased deprivation? Well, there's a lot of possible mechanisms. No one's really discussed in the literature why this might be, but we've spitballed and come up with some ideas. Access to care is certainly an issue, and people in more deprived areas tend to seek care later. So again, these people probably have a couple of jobs, working hard, don't like to go to the hospital, don't like to go to the doctor, they're going to go later, right? Or they're not going to go at all, which you would expect to maybe decrease that incidence. But it seems that we're talking about a pretty severe illness, right? So it's probably unlikely that these people, if it's severe enough to be a hospitalization, because you can go to the emergency department and have pneumonia and just get discharged. That's not counted in any of these data. That's not a hospitalization. You have to be admitted to the hospital to be in this particular study. So if you're severe enough, it seems that people are going and we're getting more. So, but again, you think about like Kira's study, coal ash, and all the environmental pollutants in the West End where all the cases are. We know that that's highly associated with lung injury. And did I say Kira? Yeah, I meant Chris. Sorry. Case. Sorry. So that's certainly a possibility here too. Plus, we have different risk factors in these groups. Certainly, there's higher smoking. If you look at smoking, it's going to be the same. Smoking is going to be highly related to lung injury and highly related to getting infection. Also, there's a lot of biological evidence for this pathway. Social deprivation, even not individual deprivation, leads to chronic stress. Chronic stress leads to impaired immunity, and impaired immunity leads to more infectious diseases. It doesn't necessarily have to do with your body's response to your living conditions. Severity. So why might severity be increasing? Well, risk factors probably. If we look at the decrease here, that's because of age. But if we look at actual increased severity, it's probably mostly due to risk factors. And access to care. So, again, I mentioned that individuals in higher deprived areas are probably going to seek care later, which is definitely true. And one of the important measures for how well you're going to do once you get hospitalized with pneumonia is how long have you had symptoms. And we've seen in prior studies that we've done in Louisville that some individuals are going to wait 2 to 3 weeks after they get symptoms of pneumonia. Not just, I have a fever and I'm coughing a little bit. Like, you have pneumonia, you're in bed with a 105-degree fever and you feel like you're dead. They might wait 2 or 3 weeks till they come. So it's going to be much worse. You're going to have a much worse prognosis than if you waited a couple of days and you're like, I got a bunch of vacation days, I'll take 2 days off work, go to the hospital. So, outcomes. Again, I have to preface this, of course, with these are all-cause mortality. We're looking at, these are both the mortality figures. So, after a year, you've been discharged from the hospital, your mortality could certainly be due to something else, particularly in deprivation areas, right? There's violence, there's a lot of other things. There are other comorbid conditions that might lead to death. You also might get readmitted more. You wait a long time to come into the hospital and make it out. Readmission is very common for these people because once you get lung injury, you're predisposed to lung injury the next time too, or infection. So why might this was the African American black race, why might that be protective for 30-day mortality? That was, when I found these results before I found that other article, so I'm like trying to figure out why this might be the case. And Mike Fine put it perfectly in his particular study, which actually ends up being the case here as well. It's largely almost all due to the fact that rich white people do not resuscitate orders and advance directives. So you come into the hospital and you say, you know what? If I need to be ventilated, don't do it, let me die. That's what happens when rich people go to the hospital. They have all the legal documents that they don't want to be resuscitated. They don't want the paddles to be code. People that don't have the mechanisms to get advanced directives get more care in the hospital. They get a bunch of tubes, they get a bunch of drugs, they get a bunch of stuff, and they make it out. So that's the difference, it seems to be. Sir?
Don't mind interruption. I'm noticing the strongest protective risk factor in the slides is body mass index.
That's correct.
Is there an explanation?
There's absolutely an explanation. Just published a paper explaining this. So most of these people, so the past 2, 3, 4 years actually, influenza seasons have been pretty mild. So most of these cases are going to be bacterial pneumonia. And there's a lot of evidence that for people with bacterial pneumonia, increased BMI is protective for all kinds of clinical outcomes. And what they think the reason is because a lot of times when you die with these diseases, it's because of your body's response. When we have H1N1, we heard about the cytokine storm, or H5N1 that kills everybody. So when you have increased fat cells in your body, they release adipocytokines and different cytokines that increase inflammation at your baseline rate. So you're walking around at an inflamed state. So when you get an infection, your body can't mount too much of an extra inflammation. You're already kind of used to what's going on. Right? So you don't die from this inflammatory response. The plaques in your arteries don't get dislodged because your body's already used to stabilizing that. If you're not used to this inflamed state, you're young, you're thin, you exercise all the time, you get an infection, it's going to dislodge you and you're going to... But for influenza and viral infections, it seems to be a little bit different. One sec, sir. So for influenza, at least during H1N1, it seemed to be completely different. So the impact of BMI for bacterial infections is protective. For viral infections and influenza, it's the opposite. It's actually hugely different. So you might go from a baseline risk of death of 5 to 10% if you get pneumonia, just if you're healthy and have regular bacterial cause, down to maybe 2% if you have a BMI over 40. If it's a bacterial cause. For influenza, you start at 5 to 10%, and it might go up to 60% if your BMI is over 40. Well?
Just a comment on BMI, there could be other factors like if patient is obese or something, they may have some other comorbidities. Because of that, they may have more medical care. So you are more catching up the things much faster, you are treating the things much faster compared to those who don't have less BMIs. And when we have like specific groups, the race groups, not getting care, so could be that factor.
Sure, great, yeah. So we have these more advanced directives in affluent areas. We do have increased frailty in whites due to older age, because the difference in the age distribution between blacks and whites in Jefferson counties, it's there, particularly in, it's modified by where you live, certainly. And all-cause mortality is just that. It could be death due to something else, who knows. So there's absolute limitations to the study, a lot of limitations just like everything else. We're not dealing with outpatient pneumonia, where most of the pneumonia is. So I said the incidence of hospitalized pneumonia in Jefferson County in the United States lies somewhere around 650 per 100,000 individuals. If you look at actual like pneumonia everywhere, if you just go to the outpatient clinic or you go to the emergency department and get some antibiotics and go home, but you still have pneumonia, it's going to be way, way higher than that. You're probably looking at 10, 20 times more, at least. We don't have any data on vaccination, so obviously vaccination is the biggest public health success probably that we've had in sanitation. There's a lot of debate as far as how good pneumonia vaccines are. I'm a huge proponent of vaccination, so I think everyone should get every vaccination that's available, so don't take this the wrong way. Please get everything. They're not bad. They probably decrease severity somewhat, but really the most effective pneumonia vaccine is going to be the one for Streptococcus pneumoniae. It's called a pneumonia vaccine, or pneumococcal vaccine. So the most common cause of CAP is supposed to be Streptococcus pneumoniae. So we vaccinate, well, the way this transmission occurs is kids are highly colonized with this organism in their throats. And they pass it on to adults, and adults get pneumonia with it. The kids don't get pneumonia, the adults get it. So the kids are killing all of us from many levels of life. Yeah, not just transmitting strep. So, but the issue is there's like 100 serotypes for this particular organism, and the more serotypes you put in a vaccine, the less effective the vaccine is. So they try to find the serotypes that are causing the most severe disease and the most common, and they throw them in the vaccine and hope that you don't get serotype replacement, and after you've vaccinated kids for 20 years, then you have the same amount of cases, just different serotypes. But we don't
So
have
did they change that?
well, that's part of this study. Actually, we got urine from everybody that's been sent to Germany to test for serotypes to see what's happening over time. It seems like there's some serotype replacement, but not as much as theoretically thought. We do have some data on vaccines, though, and that's going to be a future study. Root Care Coach Group spent a lot of time calling. Anyone in here do any of the phone calling for a study? Yeah, I think it's probably terrible. Called all the insurance companies and all the primary care physicians' offices to get documentation of vaccine receipt. Because most of the time, vaccine studies, we just use self-report. And we know self-report's bad. It's really, really bad for a vaccine. Really bad. Probably 30% agreement. Maybe. And of course, we don't have any data on environmental factors that are absolutely going to be related to this disease. So what can I conclude? Well, one thing I conclude is that Jefferson County, Louisville, is still highly segregated. And we certainly have health-related issues on either side of the tracks being Interstate 65. We have pockets of things in here. This is the airport, by the way, so there's never anything in the airport unless you live in the airport. Probably you might, travel a lot. So we need to dive into this a little bit further. This particular study may get a fourth year. There was a third year that was kind of a partial year, but it may get a fourth year. If it gets a fourth year, we're going to do a lot of individual level measurements of disparities, because again, this is aggregate levels of deprivation. It may not be the best measure. Probably not. Certainly not the best measure. It's probably hard to tell what the best measure is, but we can collect a lot more things from an individual level. And that's the plan into the future. Can talk a little bit now. So I'd really like to hear some thoughts from everyone, because I'm starting to think about this manuscript and how we might put all this together and what some of the issues may be, or what some other explanations may be. Thank you.
Do we have time for questions?
Sure. You talked about access to care. Did you overlay actual amount of facilities in those areas to also, basically reinforce everything, like, hey, there's only a couple of facilities that provide this sort of additional treatment, and then also perhaps add that with the nonprofit organizations who may be doing similar work, because if it's access, because I know, for example, after that work that I've been doing, that there are a lot of other organizations that may not necessarily come up immediately as, here's a hospital, here's what you go to, but there's a lot of work that's available to those particular individuals that might not necessarily undercut, but provide more perspective on what's going on, or why access to healthcare might be that maybe not the sole issue,
Sure.
or at least not the primary factor.
Yeah, and that's something that Edie's actually going to look at a little bit with some of these data and in the study we're doing. Is Louisville's a little weird. I don't know. I think I'm not from here, but the longer I live here, it's like people love it here, right?
We have these signs all around town.
Yeah.
Keep Louisville weird.
Right? Yeah. So one thing we found out from the hospital association is, one of the limitations originally of this study, we thought that maybe people are going to go somewhere else for care. There's 2 hospitals on the other side of the river. Nobody goes there for medical care. It's like 99.8% of the people that live in Jefferson County, if you get sick from medical care, you go to a hospital in Jefferson County. Unless you're have a summer home or winter home in Florida or something. We wouldn't have caught you then. But the hospital distribution is weird, because we have, downtown hospital campus, like half of the hospitals are within a block of each other. And then you have all the East End hospitals, right? So there's no, you have St. Mary's and Elizabeth for the southwest end, but that's a very, very busy hospital. I think that was probably the highest enroll overall. It was up there.
For disparities, yeah.
Yeah.
Otherwise, it's not an Audubon. We have a lot of issues.
Yeah. So Audubon too, you kind of get some of that area. So we're going to start looking at some measures of distance between your nearest hospital and the hospital that you actually went to, and then some of the differences. I mean, for pneumonia, it's kind of a basic disease. I mean, if you look at your physician and any physicians in the room, I want to badmouth everybody. You know, you're a doctor, you get a flow chart, right? Yeah. Dr. McKinney, you got a flow chart for a long time. It's like, you have pneumonia, okay, you get macrolide and a beta-lactam, or you get a quinolone, okay, go home. Let the intensivist take care of you now. So that's definitely something we need to look at. I'm not aware of any nonprofits that are doing pneumonia stuff. I know American Lung is around, but I don't think they're doing a lot of, it's mostly asthma and COPD, which are certainly important things in Louisville particularly, but it's all kind of this continuum of lung disease.
I know CHE, the health equity people, they've done a lot of, they do a lot of mapping work where they're overlaying on Louisville all the varying healthcare facilities, including ones that often get missed, including as well as connecting it with transportation access, which is particularly obviously important to consider. So, it's not necessary to redo the wheel, because I know they've already done the work, including the coding that's just generally available because we've used it.
So I'm still fascinated with that protective effect of being on the data. And you noted that that's for mainly streptococcal
Bacterial process.
bacterial.
Could be any bacteria.
So the viral H1N1 goes the other direction. You did show that data, that's what you said. Right. So the other blacks were protected also.
For 30
Bacterial pneumonia. For non-bacterial, is that association with the other direction?
I didn't look in these data separating out pathogen, but I'm trying to think of, so the original data that we looked at BMI with, we didn't collect race, which was kind of a bummer that we found out was a problem later. So here we have race, but there's really not too many influenzas because they were real mild seasons. So we could probably look at it, but I'm not sure we have enough data to
Those
justify that.
odds ratios are not mutually adjusted, they're multivariate adjusted.
They're multivariate. Yeah, so the BMI one was all propensity adjusted, so it's like
The
50
BMI is
variables.
adjusted for race, age, things like that.
Yeah.
Interesting. I like the cytokinin theory. You've got nutritional reserves to some extent with higher BMI. And one of except in certain elderly populations, perhaps one of the things that cytokine storm does is stimulate protein degradation. And that can really tank you if you've not got it. I mean, people with higher body mass index don't just have more fat, they have more muscle.
Yeah.
So protection
I mean, at the end of the day, unless you expect, if it's in the summer, just eat more donuts and you'll be fine. In winter, where it's flu season, you might want to eat some donuts and then go for a run.
amino acids or something, you need not donuts.
Donuts are the best thing ever.
Any other questions?
So Tim, do you have any?
I thought R was the best.
Yeah, that's true. It's the second best thing ever. Okay. Dr. King?
Yeah, any information about number of individuals living in each home in various areas of the city? If that was perhaps one reason why it might be higher.
Yeah, that's a very important consideration. So that's one of the variables in the deprivation index. How the density, I think, is what they're trying to get at. But that's going to be absolutely. I've kind of started developing a questionnaire for if we get this fourth year of funding to what are we going to ask people, and that's one. How many people live in your household? How big is your house? We can get how big is your house, kind of. So we have addresses, but getting an API for like Zillow or Trulia or something to pull down the square footage of the house is
It should be in consensus if it's
a pain.
group level. There's,
Yeah, for group level, we want to do individual level next.
Oh, okay.
It's a pain.
How many square feet per person?
Yeah, and then you get into apartments and it gets really difficult to deal with. And that's another thing is, you know, you live in an apartment complex that may not have anything to do with your habitat. It's your cohabitat, you know, all the other people living in your complex. So.
Also, with the differential mortality rates, you would expect if whites were more likely to have do not resuscitate orders, for example, they'd be getting substantially less care, and then the cost of their hospitalization would be far less. Do you have any data to support that?
We don't have any cost data. I think, so we can get it, at least it's been pretty easy to get it from Mobile Hospital in the past. I'm not sure about the other hospitals that probably do it, but one thing we've noticed is that, particularly with U of L being as, you know, kind of hospital it is, costs are, you know, not really the reality of what it costs, right?
Yeah, right.
So if you have insurance, the cost might be higher than if you don't have insurance,
Charges
not just
versus
charges.
costs,
Yeah. So it's
Okay, I'm curious, so when people present to the hospital with pneumonia, I mean, it has to be the diagnosis upon admission.
correct. And then so I didn't put up the criteria for pneumonia here, but there's specific criteria for clinical diagnosis of pneumonia. And then to be called pneumonia in this particular study, when you were discharged, you couldn't have an alternative diagnosis. So.
I guess, so is there any issues with coding across the county centers and, I guess, compliance for coding for pneumonia? Is that something that you can address in this type of study?
Yeah, so this was all clinical diagnosis of pneumonia. We didn't have no administrative data.
Okay.
We used it all. But if you do look at coding, it's a mess because they're going to charge, I mean, it's going to be whatever you can get the most
Oh,
money
yeah.
for, right?
We
The most
explored that in
reimbursed.
my classes, talking about the differences in coding and how the difference in mortality rates change because of
Depending on
those issues in
yeah.
coding. Yeah.
So that's a big one with administrative data. And actually we compared our incidence results to a huge study that was using, I don't remember how many, it's like 120 million cases. And they had kind of their age, it was NIST data, so they had their age incidence broken up, and we compared ours to that, and it was almost exactly the same across every age group. So when we put that, I think in the original paper, was that maybe once you get so many millions of people, the issues with administrative data may be washed out a little bit, and they seem to match the clinical stuff. But if you're looking at a couple 100,000, you might run into these big issues of huge biases because of the difference in code.
Yeah, so obviously the big focus on this is understanding the impact of disparity. And one of the things you talked about was access to care. I know we talked a couple weeks ago about finding primary issues of impact. So is it access to care? Is it just how much education you have? Have you looked at different ways of adjusting specifically for just those issues alone? So is it just access to care? Is it your knowledge of, I need to go to the doctor right now.
Yeah.
Whatever those cases may be, as opposed to using just disparity, which can obviously be a math problem, other things.
Sure. Yeah, I think that's going to be something that we're going to look at in the next, when we start getting individual level data, because I still have kind of a hard time dealing with spatial data. Although it's block group level, it's pretty good. It's still not individual. It's still not what's happening in that particular person necessarily. So I think we'll start getting at access to care and individual perceptions. This is going to be important, and because you might maybe go back to the theory of planned behavior and see behavioral control.
Yeah.
You might feel that you have no control over something. You might have complete control, but maybe that could modify everything. So your perception might be everything in this case too. So, but I also wanted to say a huge thanks to Gavin for talking about this and Dr. Wallace, because we got together several times to talk about some of these issues. Even at Sergio's, it's a good time. We got a lot done then. Go to Sergio's, it's a great place. And Doug Lorenz, because we did a couple other analyses first. He helped me a lot with the statistics. There's a couple other methods we tried that are really cool. So if you're ever dealing with data where you have individual level measures and group level measures, you don't just have to do mixed effects regression. There's some other really cool things that we did, like resampled the population. So took one individual from every block group and resampled it 10,000 times and ran 10,000 regression models. Those took a really long time to run. And every time I ran it, I'm like, oh no, I forgot this variable. It's like, there's another day gone. So, but those are really cool too, and those would be pretty impactful. But we didn't have enough outcomes really to be able to do that. So, I think it's time.
Okay, before you leave, could you please fill out the evaluation form in front of you? If you need a copy of it, I'll have it. Let me know. Thank you.
Thanks again, everybody. Appreciate it.
Yeah.